خلاص إذن هسه الساعة 11 فأل start this talk. أنا زميلكم أحمد محمد الحسن، خريج الدفعة السادسة جامعة الرباط، حاليا شغال ريجسترار بتاع كارديوثوراسيك سيرجري في بريطانيا. My topic will be surgical precautions in the time of COVID-19. إن شاء الله يعني استفيدوا منها I'll try my best not to take a long time. I have no disclosures. Before we start, it's important to know that the surgical teams are at a uniquely high risk of COVID-19 exposure. فعشان كده a well-rounded understanding and keeping up to date with relevant guidelines كان local guidelines بتاعت المستشفى، كان guidelines بتاعت اللوكال المجلس الطبي أو الجمعيات الجراحية المختلفة that are relevant to your specialty. لازم الزول يكون عنده a well-rounded understanding of this. فبناء على ذلك الغرض من البرزنتيشن دي مش تعليم السيرجري per se، لكن to serve as a general guide and a foundation of knowledge to build on. أهم حاجة في ده كله إنه there is no substitute for sound clinical judgment. ففي ال perioperative period هنبدأ بال preoperative precautions. في البداية when we were setting up the surgical service عندنا all the elective operations were postponed. بعد ما المستشفى والinstitutes developed a local guideline, they reintroduced elective operations لكن they proceed with caution. بمعنى إنه they screen patients for COVID-19 ولو في أي indication that these patients can be COVID positive, they would postpone the operation. If it's cancer surgeries, they would postpone it for 2 to 3 weeks. If it's uncomplicated benign surgeries, say hernias, for example, abdominal hernias or inguinal hernias, they would postpone it for a month or more لحد ما السيرفيسز ترجع تاني. أما بالنسبة for essential, urgent or emergency surgeries, the institute، المستشفى، إدارة المستشفى، الجراحين، ناس التخدير، ناس الانتنسيف كير، كلهم مفروض to develop a clear plan for provision of emergency surgery during the pandemic. وإن شاء الله we'll touch on this as we go along. والنقطة الثالثة المهمة for patient selection زي ما ذكرت قبل شوية is health screening for all patients whether or not they're symptomatic. طيب في موضوع ال patient selection وال screening, it's recommended for all symptomatic patients undergoing cardiothoracic surgery و general surgical patients who will require critical care admission to be screened. The screening for surgical patients consists of symptomatology، يعني حيكون عندك healthcare questionnaire تسأل فيه العيان عندك قحة أو عندك قحة أو fatigue أو malaise أو symptoms of COVID-19 upper or lower respiratory tract symptoms. But this is the first part of screening. The second part includes swabs, nasal and throat swabs for COVID PCR. The third constituent of screening is the blood tests. ودي it was explained in details في المحاضرة، في أول محاضرة قدمها لنا محمد فيصل الله يديه العافية. if you want to know more about this بس أرجعوا للمحاضرة بتاعته مفصل لكم بالتفصيل. The fourth component of preoperative health screening for COVID is CT chest. وإن شاء الله زميلنا من الدفعة الأولى دكتور إيهاب consultant radiologist will give us a talk about radiological features of COVID-19. طيب هو عملت 4 screening methods دي. One of them or 2 or all of them suggested that the patient may have COVID-19 or diagnosed patient with COVID-19. ففي الحالة دي you would discuss the surgeon, the anesthetist will discuss the urgency of the operation. ديل أقل اثنين في ال NDT meeting as a guide, as a general guide مفروض يكونوا متواجدين. In addition to the surgeon and the anesthetist, you can involve the intensivist for post-operative care to determine the operation urgency. هل تتأجل ولا هل تتعمل؟ If surgery is to be done, the Joint Royal College of Surgeons هنا في إنجلترا they published a guide إنه هو بيسهل للناس to approach specific surgeries in all surgical specialties. I will go through this I think in the next 2 or 3 slides. The importance of screening for patients is that there is a concern of potential significant increase in morbidity and mortality للpatients with a higher than average incidence of mortality post-op للعيانين اللي عندهم COVID-19 أو who were operated on and they had COVID-19 during its incubation period. This is the clinical guide بتاع ال Joint Royal College of Surgeons اللي هم قسموا العمليات المهمة للعيانين ل priority 1A اللي هم emergency surgery اللي هي العمليات اللي لازم تتعمل within 24 hours. Priority 1B, these are the urgent surgeries which are to be done in 72 hours. Priority 2, 3 or 4, these are the surgeries that can be postponed. مثلا 2 can be lung cancer surgeries or bowel cancer surgeries, early stage cancer surgeries. Level 3 or 4, they are benign, uncomplicated surgeries or conditions. I will give you an example of it, of the emergency surgeries. Lakin with regards to the CT thorax indications or guide preoperatively, the Royal College of Radiologists advises that a CT chest prior to elective cancer surgery should be done. A CT chest should also be done in abdominal emergencies, especially the abdominal emergencies where you had an abdominal CT done. With those, you add a chest CT. The guide also advises that patients undergoing thoracic surgery, cardiac surgery, complex upper GI surgery, or those requiring post-operative critical care admission to have a preoperative chest CT as part of their screening. The important point to note is that if the CT is negative ما معنات الناس ما تلبس PPE حول العيان أو العيان ما يلبس ماسك. فملخص الجايد is لو CT findings normal وباقي screening normal, you proceed to surgery as normal. لو CT findings are indeterminate يعني ground glass appearance لكن ما ماشي للكوفيد شديد واحتمال يكون ماشي لناس COPD أو الكرونيك chest infections أو كده, you repeat the full assessment in 1 or 2 weeks. ولو ما في تغيير دي حاجة اتضحت إنها chronic situation, you can proceed to surgery. But if you have the classical features of COVID-19 and the surgery is postponable without affecting the health of the patient, you would reassess the patient in 2 to 4 weeks. ونرجع تاني للكلينيكال جايد بتاع تحديد الأولويات الجراحية. وهنا I'll give you an example of the emergency general surgery procedures. يعني في الدوكيمنت دي عندكم ال different surgical specialties موزعة and to operate on what and what not to operate on. So for example, emergency general surgeries that could be performed within 24 hours include emergency laparotomy for various indications, peritonitis, ischemia, necrotizing fasciitis, bleeding that's not responding to more conservative measures, appendectomies or appendicitis, post-operative complications, intra-abdominal trauma, which can't be managed conservatively, مثلا in the presence of splenic laceration or high-grade renal laceration, for example. طيب, this document also describes the other kind of surgeries, as you can see. As you can see here, you have oral maxillofacial surgery, plastic surgery, urology, orthopedic surgery, ENT, neurosurgery, cardiothoracics, vascular, pediatrics, وpediatric orthopedics. ديل هنا ناس الإمرجنسي, وعندهم table تانية for the urgent surgeries, and then there's another table for elective surgeries. هحط الرابط بتاع الببليكيشن دي في الكومنتس بعدين كده لما نخلص. معلش أنا ما قادر أشوف الكومنتس هسي, لكن when we're done I'll put it in the comment section عشان لو زول داير يقراها in more detail. طيب, emergency surgery عرفنا إنه you would operate on them and assume that they are all COVID-19 positive, because you won't have enough time to do the COVID-19 screening for emergency surgery. For example, aortic dissections, stab wounds, so on and so forth. Urgent cancer surgeries, في مستشفى في لندن, Bart's Hospital, they published a guideline referral, يعني اللي هم خاتين فيه for non-malignant indication referrals, procedures are postponed. لكن referrals including cancer or urgent general surgery, if the patient is low risk COVID infection, eventually will have surgery. Possible infection, assess the patient, see if you can postpone the surgery or perform the surgery. لكن known positive COVID, they would rather postpone the surgery. Of course في النهاية maintaining patient health in mind. طيب, عملت screening للpatients and you want to take the patient to surgery. وقبل ما توديه surgery you have to consent the patient. أهم شيء في consenting process of patients, you have to inform them that there's an uncertainty regarding their post-operative recovery, بالذات في وقت pandemic ده. You should balance the risk of either delaying surgery or putting the patient through alternative modalities of treatments. والكلام ده مهم تنبهوا العيان وتكونوا واعين به, لأنه there was a paper published retrospectively analyzed 34 elective surgery patients. خلاص, 34 عيان ديل were operated on during their incubation period of COVID-19. يعني 34 عيان had COVID-19. Post-operatively, all these patients developed COVID-19 pneumonia. 34 patient. 15 of these patients were admitted to intensive care units, and the mortality rate of operating on patients with COVID-19 was as high as 20% for elective surgeries, which is much higher than usual. طيب, the most common complication that patients had and passed away from were acute respiratory distress syndrome, shock, arrhythmias, and acute cardiac injury. When reading this paper, I'd take it with a grain of salt, لأنه يعني I wouldn't take it at face value, لأنه ما شرحوا فيها ال ASA status of the patients. لأنه في 2017 it was published that the higher the ASA grade of patients admitted to ICU post-op, the higher the mortality. For instance, ASA grade 1 patients admitted to ICU post-operatively, their mortality rate was around 0.3%. As you go up the ASA grade, تصلوا لحد ASA grade 4, the mortality rate can be up to 26%. The other weakness with this publication is that it's a small sample size. طيب كده, the pre-operative patient preparation has been done. What about PPE in surgical practice? As COVID-19 becomes more established in the community, you will find by time that asymptomatic patients will present to hospitals for other reasons. Yani, for example, for back pain, for example. And based on this, the hospitals should have measures in place even when dealing with asymptomatic patients. Staff should be required to adhere strictly to universal precautions, frequent hand washing, and elimination of unnecessary staff, اللي هم those who are not directly involved in this specific patient care. فبناء على ذلك, all surgical staff should be educated on PPE or personal protective equipment. Yani, what is PPE? The components of PPE, masks, visors, gowns, gloves, and the medical and nursing staff should be educated on management of COVID-19. The authorities should also ensure appropriate PPE availability for all staff, اللي هم إدارة المستشفى طبعا. لأنه appropriate use of PPE protects patients and staff from COVID-19 transmission, and by extension, the patient's families and your families. The medical, the nursing, the healthcare associated teams والناس اللي عندهم contact with patients should train on donning and doffing techniques. خطيته هنا in bold underline. Donning معناته putting on PPE, و doffing معناته taking off PPE. Public Health England اللي هي ال PHE, which is one of the governing bodies هنا في UK, recommends that a face fit test be carried out. Face fit test دي معناتها بس يشوفوا الماسك أو you test the masks for PPE on your face. والماسك يعني it should form a very good seal. لازم يكون كاتب يعني. خلاص. فحسي المحاضرة بتاعت البي بي اي حتكون إن شاء الله مع سينيورنا دكتور محمد الهادي, who will explain to us من الدفعة الثانية, who will explain to us the components of PPEs and what it entails, well, protection levels of PPE. العموم, all surgical staff, whenever you're dealing with patients, you should have PPE on. When you're transferring a patient, هنا في اليمين, when you're transferring non-ICU patients to theater, يعني من العنبر, من الحوادث, العيان نفسه لازم يكون wearing surgical mask. The patient should wear a surgical mask. The transfer team, التيم اللي حيوصل العيان الثياتر, مفروض برضو يكون لابس PPE, أقلاهم apron, gloves و surgical mask as well. Eye protection is required, well, full PPE is required when transferring an intubated patient. You have to put on full PPE, including visors, goggles, masks, and protective gowns to decrease the risk of contamination from aerosols. The patient paper notes والfolders والdrug charts والحاجات دي كلها مفروض تتخطى في plastic bag أو كيس, والكيس ده بيتخطى في الثياتر في الclean zone, which we will touch on in a few slides. لما العيان يصل الثياتر, السرير بتاع العيان بيفضل جوا الثياتر برضه, لأنه it's assumed contaminated as well. طيب, وصلت العيان الثياتر. How is this theater set up? What are the anesthetic precautions? And what are the surgical precautions that you should undertake? طيب during this pandemic ناس المستشفى and the surgeons and the surgical staff should develop a dedicated COVID-19 operating space. جوا ال operating space أو جوا غرفة العمليات الوحدة دي المفروض تكون واضحة ال clean and dirty zones inside this theater. For example, the clean zones include غرفة التخدير، غرفة التحضير scrubbing room، وغرفة المعدات الطبية أو surgical equipment room. ال dirty zones حتكون غرفة العملية ذات الحتة اللي حتعملوا فيها العملية، وال area where you are going to doff or take off your gowns and PPE. This is a blueprint or an example of a COVID-19 theater. خلاص you can see OT1, operating theater 1 and operating theater 2. In operating theater 1 you have the induction zone which is the clean zone اللي هي في الأيام العادية بتكون anesthetic room. العيان بتخدر هنا wheeled in to theater. الجراح بيجهز هنا بيدخل theater and they operate. But in COVID-19 patients do not go through the clean zone. Patients go through the back door immediately into theater. They are anesthetized and intubated in theater and surgeons and the surgical staff operate there. لما العملية تنتهي العيان بيطلع بنفس الطريق والجراح والanesthetic team والnursing team scrub team they go through the back door or the doffing area which is the dirty zone. زي ما قلنا ال staff allocations you have the dirty zone اللي هم الناس directly involved في العملية، الناس اللي قاعدين يعملوا العملية اللي هم الانستيست ومساعد التخدير والجراح والمساعد بتاعه والسكراب والسكرابنس وبرفيوجنست if required. الناس اللي بيكونوا قاعدين في الكلين زونز اللي هم برا الثياتر ديل الناس الرونرز او السيركيليتنج نيرسز اللي بيجيبوا البلودز اللي بيجيبوا الفلويدز اللي بيجيبوا الميديكيشنز من برا للعملية. في كل الأحوال أهم شيء الجوا جوا والبرا برا. So no staff should enter or exit the theater until the case is completed. ولو بقى في a need for someone from outside to come in they have to put on PPE. طيب بخصوص ال anesthetic considerations the anesthetic team should ideally يعني use disposable equipment wherever possible. خلاص for example دي anesthetic tray و you can see معظم الحاجات هنا they are disposable for anesthetizing the patient لأنه there are 3 high risk time periods when in the operating theater. The first one is pre-oxygenating and intubating the patient والhigh risk period الثانية is the operation itself والhigh risk period الثالثة is the immediate post-operative period that includes extubation and recovery. Why are they high risk? لأنه there is a high likelihood of generation of aerosols in these procedures. بمعنى الكلام مثلا you can see هنا aerosol generation on pre-oxygenation. These images depict aerosol generation which is a very high risk undertaking. عشان كده when you're intubating a patient in the theater ما في زول غير ال experienced anesthetic team ومساعد التخدير يكونوا قاعدين جوا الثياتر. الجراح والscrub nurses والassistants يكونوا قاعدين برا غرفة العمليات. To decrease the incidence of aerosol generations some hospitals utilize عملوا شنو؟ جابوا الكيس بتاع السي ارم عملوا فيه فتحة وخدوا الماسك فيه. Okay? This will catch any aerosol generating from the patient's airways to the operating theater. It's very important to note تذكروا إنه the anesthetic team هم ذاتهم while they're inducing anesthesia and putting the patient to sleep, they are in full PPE. Okay, once the patient is put to sleep, ويجي دور الجراح وال scrub team عملوا عملية. You'd wait 10 minutes before entering the operating theater. Air handling بالعربي كده هي التكييف في الثياتر, اللامينر flow في الثياتر, usually cleans the air in theater over 10 minutes. يعني تستنى 10 دقائق برا العملية, الفنتيليشن بتاع الثياتر clears الهواء, ينظف الهواء بعد 10 دقائق. بعد ذاك السيرجيكال تيم يجوا داخلين if the patient is stable, of course. The second high risk period when operating is the surgery itself, لأنه it can be considered a form of aerosol generating procedure. وسموك الدخان اللي بيطلع من الدايثيرمي, الناس اللي بيحبوا يستعملوا الدايثيرمي كتير, it showed that the smoke from diathermy harbors intact bacteria و virus particles, and aerosols have been identified from multiple procedures including زي ما قلنا use of electrocautery اللي هو diathermy, high speed tools زي المنشار, laparoscopic surgery, especially abdominal laparoscopic, not so much thoracoscopic surgery, well, bronchoscopy. These all increased the aerosols in the operating field. One way of avoiding this is decreasing the power settings of electrocautery as low as possible, or avoid using diathermy a lot in one area. To also decrease aerosol generation, الجراح should consider two things. The first is utilize a surgical approach that could decrease staff exposure to aerosols. يعني بتعرف تعمل عملية open وبتعرف تعمل عملية laparoscopic, محبذ إنك to go to the open procedure first rather than the laparoscopic. والحاجة الثانية الجراح should put in mind إنه to try as much as possible to shorten the case of the surgery, or shorten the duration of the surgery, of course without compromising patient safety. وبرضه full PPE من ألف لحد الياء لحد ما تبرقوا. طيب, with regards to minimal access surgery, ليه قلنا use open surgery rather than laparoscopic surgery? في chest is not much of an issue لأنه you have the rib cage, فماسكة لكم chest فوق, the surgical field is already available, no insufflation required. بس برضو if you use a diathermy in the chest, it should be used cautiously. أما for laparoscopic surgery, المشكلة بتجي من وين؟ بتجي from the provision of artificial pneumoperitoneum, and this increases the risk of aerosol exposure لأنه بتنفخوا CO2, وال CO2 معروف إنه أثقل من الأكسجين, فبيقعد في البطن بيعمل لك ال surgical field, والناس بتكون مبسوطة إنه operate, والهواء ده ما بيطلع برا لأنه التروكار المخطوط في الأبدومين it forms a seal, فصعب الهواء to escape. فالزول شغال بالدايثيرمي وال CO2 جوا وكله مضغوط ومبسوط. The minute you finish operating and you release the trocar, all that air, all the aerosol that's within the abdomen is dispersed into the operating theater. One way around it, يعني الناس اللي بيستعملوا laparoscopic surgery still, they use air extraction devices أو suction, بيسحبوا الهواء كله قبل التروكار, قبل ما يمرقوا التروكار, decreasing the incidence of aerosol in the operating room. طيب, the third high risk period in the intraoperative or perioperative phase is the extubation period. And once they extubate a patient, there's a high likelihood that patients will cough. But extubation and recovery, initial recovery of the patient happens inside theater, كويس, before transferring the patient to a dedicated unit. طيب, خلصنا العملية، جبت العيان، عملت العملية، قفلتوه، خلصت العملية، صحيتوه extubated والعيان recovered. The next thing will be وطلعت العيان. The next thing will be theater decontamination. نظافة الثياتر قبل ما العيان اللي بعده يجي. Theater decontamination includes cleaning and ventilation. Why is this important? ببساطة لأنه the whole theater should be considered contaminated, لأنه with the generation of aerosols during intubation وال surgical procedure وال extubation, it's been noted that viral particles have been found in the surfaces of rooms والshoes, the aerosol can survive in the air for at least 3 hours زي ما ذكر أخونا دكتور محمد فيصل. It was a lab experiment and they did aerosols ولقوا الفيروس في الأيروسول can stay in the air for up to 3 hours. فالجراحة دي عبارة عن aerosol generating procedures. برضو when you're dealing with patients you have to make sure the PPE is important, لأنه the virus has been found in nasal swabs, pharyngeal swabs, في السبيوتم، في البرونكس، في الجاستروintestinal tissue، في البلد، وفي الستول بتاع البيشنتس. okay. فطيب أهم حاجة في الثياتر decontamination is the ventilation. فبتخلوا المكيفات شغالة في الثياتر. وأنا متذكر في السودان كان في ثياترز كنا بنستعمل split units ما حنك، المكيف ventilation يكون شغال والفلو يكون ماشي خلاص. once the patient comes out of theater, the staff should also come out of theater for about 15 minutes, اللي هي it gives you a chance of 5 air changes. الفنتيليشن ده بينظف الهواء السيركوليشن بتاع الثياتر 20 times في الساعة. Public Health England recommends 5 air changes before cleaning the theater. يعني تخلص العملية تمرق العيان تستنى 5 air changes اللي هي حتكون about ربع ساعة. لو قلنا 20 air change في الساعة، 10 في نص ساعة، حتكون 5 في 15 minutes. After 15 minutes الناس اللي بينظفوا الثياتر يجوا يدخلوا clean the theater and then call for the next surgery or the next patient. يعني all in all from الناس تستنى نص ساعة أو 45 دقيقة من خروج العيان الأول من غرفة العمليات لإدخال العيان الثاني غرفة العمليات. طيب giving yourself a chance for ventilation and decontamination. دي ذكرتها، قلتها 5 air changes 15 to 30 minutes. Leave each theater empty for 15 minutes. لما 15 minutes تتم تجوا تنظفوا الستاف يجي ينظف الثياترز، و minimum time before sending for the next patient is 30 minutes. في نهاية اليوم لما تخلصوا العملية the theater should undergo a terminal clean on a daily basis. افتكر كده اتكلمنا عن ال pre-operative patient selection وتمينا رحلة المريض من المقابلة والسلكشن والسكرينينج والجايدلاينز بتاعت الراديولوجي اللي هي CT thorax. We touched a bit on the transfer of patients to theater والأنستيزيا والعملية نفسها what to expect what not to do والextubation and recovery periods والcontamination decontamination. وفي نفس الوقت إن شاء الله بس أكون وصلت لكم أهمية ال PPE في التعامل مع المرضى who are undergoing surgery. وبالذات أهم شيء طبعا أهمية ال PPE في غرفة العمليات، اللي هي it can be a source of abundant aerosol generation. In summary كده, you'd assume that all patients undergoing surgery are COVID positive, especially emergency or urgent surgery. If you have time, you should screen all surgical patients according to the local policy بتاعت المستشفى بتاعت المجلس الطبي. المهم the local policy اللي عندكم. All intubation, extubation and recovery should be undertaken in theater. The surgical staff, أهم حاجة مهمة شديد إنه you should always wear aerosol protection PPE, tightly sealed face mask, goggles or visors, طبعا ال surgical cap والgown و double glove, especially when operating. If you can, try to avoid laparoscopic surgery and the use of diathermy. If you can't, you should undertake extra precautions like adding in smoke extraction devices. When transferring non-intubated patients in or out of theater, the patients should have surgical masks on them. There are a couple of references, well, a few references where I based this talk from. This last reference هنا دي فيها الليستة بتاعت emergency surgery بتاعت the Royal College of Surgeons prioritization list. فالكوبي تحط لكم في الكومنت بعد شوية إن شاء الله. وعلى كده this marks the end of my talk. Thank you very much for your time. إن شاء الله يعني تكونوا استفدتوا منها، ومعليش يعني لو طولت عليكم في الكلام، وبرضو معليش لو الصوت ما كان واضح. المروحة بتاعت اللابتوب يعني لو كانت أعلى من صوتي، لكن المهم إن شاء الله الفكرة تكون وصلت عبر السلايدز والكلام المكتوب في السلايدز. وشكرا.